Good afternoon, everybody. Now we come to the last session in this hall in the audiology section, which is related to electrophysiology. The title is Electrophysiology, a Good Guide, and the moderator will be Dr. Dalia Hassan, Professor of Audiology at Ain Shams University, and she is going to present the panelists for this topic.
Good afternoon, dear professors and colleagues. Thank you, chairpersons. I know it's the last activity in this day. After a long, fruitful scientific day, we will pass through quickly the last round table about the electrophysiology, a good guide. I'll be pleased to present Professor Dr. Mandala from Italy. Have a seat, please. Professor Dr. Nadia from Ain Shams University, Egypt. Have a seat, please. دكتور وفاء حضرتك لا خليكي مظبوط كده. We are four here. لا اتفضلي Quickly, auditory evoked potential are electrophysiologic responses arising from the peripheral and or central auditory system structures in response to acoustic stimuli. They consist of reproducible positive or negative peaks, latency, amplitude waves with behavioral correlation, of course. They can be used for hearing assessment, audiologic, neurologic diagnosis, intraoperative monitoring the progress in audiologic rehab, hearing aids, cochlear implant, and of course for research purposes. The roundtable today about the electrophysiology, a good guide, will include an interesting new topic about the neuromodulation of auditory cortex in cochlear implantation, the frequency following response to assess the speech and noise ability in hearing impaired children, and KP1 as a golden biomarker in cochlear implant journey. We will start the presentation by Professor Dr. Mandala. Please.
Thank you very much. Yeah, that's perfect. Okay, thank you very much. Thank you very much to the president and moderator. I will talk to you about pretty future research. So it's something really new. This is the first experience in the world literature, and I hope to be as much as clear as I can. So we know that our brain can be stimulated by magnetic field, so it can be stimulated either in an excitation or inhibition way. So it comes from many years ago, from 43-48 AC, from Scribonio, that observed that placing a live torpedo was delivering a direct current over the scalp of patients with a headache for improving the headache. But stimulation of the cerebral cortex in human subjects come from Morton and Merton in 1980. The term transcranial magnetic stimulation and all the opening field of research with many FDA-approved applications nowadays, like from some psychiatric disorders like resistant depression, we have to thank Professor Barkett from 1985. We will talk about a specific kind of neurostimulation that is called repetitive TMS, so repetitive transcranial magnetic stimulation. As you can see, in terms of research, it's a really growing topic, and you will see in the future that we will, I'm sure it will have a lot of application. We know from literature that it has been proposed for treatment of tinnitus. It seems to give a temporary relief from tinnitus, but there is no scientific evidence that it works. That is probably due because the precise location of the dysfunction in the central nervous system related to tinnitus is pretty unclear nowadays. It's known that also in normal subjects you can get some kind of improvement regarding higher functions in terms of the auditory system, especially for speech perception in noise, and it has been demonstrated, targeting obviously the primary auditory cortex. This is what we did. This is our idea of neuromodulation of the auditory cortex. You can see all the parameters. This is neuronavigated, so it's based on MRI modeling on each patient. So we have a precise location that is neuronavigated to target the primary auditory cortex, and this is something very important when you want to do this kind of neuromodulation study. This is all the equipment. I won't go into details. You have just to know that patients need to have 5 sessions that last 20 minutes. It's absolutely non-invasive, and it's no any kind of discomfort from the patients. The first things that we did, since nowadays TMS is an absolute contraindication to cochlear implantation, is trying to see if we could improve speech and noise in patients with a hearing loss that were wearing hearing aids. Well, you can take off the hearing aids and go on without any issue with the TMS. So it was a pretty long study. It was a double-blind randomized placebo study, because it's very easy to have a sham group in TMS. The patients will just hear the noise, but you won't get any magnetic field applied to the auditory cortex of the patients. If you think that the TMS magnetic field, it's not a static one as MRI, where you have 1.5 or 3 Tesla in every point in the space inside the bore. It's a dynamic magnetic field that can easily exceed also 3 ms for a short time. So it has a rise and a fall. So it will increase the number of Tesla, and then it will go down repetitively. These are the results in those first patients. The paper is published, and you can see that when you have a look at the simple pure-tone audiometry, you won't really get any significant effect between the control group and the treatment group. If you go with a more demanding test, as the matrix test, when we want to see the real performance in speech and noise, you can see pretty clear that there is a really strong effect that lasts over time, and those patients can gain -3 dB at the matrix test. That's pretty a lot. It can be roughly 40% in terms of speech discrimination in noise. So it's really a huge effect. Then, since we know that it was very hard to motivate our ethic committee regarding the use of TMS in patients with cochlear implant, since all the present guidelines saying that it's an absolute contraindication as well as epilepsy. For example, we know that since a long time right now, all of the companies that produce cochlear implant can produce cochlear implants that are pretty MRI safe, up to 3 Tesla. So we did this study with this in vitro study on feasibility. You see, that's me with the coil of the TMS, and we are exceeding a lot the maximum range of stimulation in order to see if we can get some malfunctioning of the cochlear implant after this stimulation. We measure also the forces applied to the cochlear implant in order to be safe that there may be no displacement, as well as temperature that could rise inside the electronic part of the internal part of the cochlear implant. And everything was really safe. All devices were tested, especially the latest device were really safe with TMS. And if you consider that this kind of an in vitro study, you won't have any skin or soft tissue that will reduce a lot the power of the magnetic fields, since that every magnetic field decreases with the square of the distance between the region and the coil. And obviously, the auditory area are not in the same place where we generally fit the internal part of the cochlear implant. This was a case report by other authors where they, by chance, this was for treat epilepsy, they placed some electrodes in the auditory area for treating epilepsy, and they demonstrated that these patients improve a lot his speech discrimination in noise. That was just by chance. This is just anecdotal, but it gives more strength to the study that we developed. And this is the ongoing study. We will, hopefully we will reach soon 40 patients. I will bring you the preliminary data. So again, we have two groups, a sham group and a study group. They are randomly divided into groups. These patients will underwent the classical TMS protocol that you saw before for patients with a hearing loss and hearing aid. They did a lot of tests, put on average, speech audiometry, the matrix, cognitive test, EEG, MBEC, P1. They did really a number of tests. I will concentrate for this lecture only on a few of them. So here you have the preliminary results of the first 19 subjects. You can see the sham group in orange and the active group in blue, and you can clearly see that during follow-up, those such a strong effect in terms of matrix test that were the patients in the active group scored -4 dB in mean versus the sham protocol. So that means that we need to have more patients and have a multicentric study. So all of you that are interested, you are welcome to contact me and participate in a multicentric study, since it's also approved by the ethics committee. I must say that all of these patients were in a plateau phase of their fitting, so they were after at least 6 months. The majority of patients was after 1 year of wearing a cochlear implant, so they were in a plateau phase of their auditory outcomes. Here you can see some other data regarding vocal recognition, bisyllabic word recognition, cognitive effort, and you can clearly see that the strong effect demonstrated with the matrix test is still visible, for example, in the cognitive effort data. Again, here you have again a measure of cognitive effort, some EEG activation, where it's clearly see from the graph on your right side that the patients who received an active repetitive TMS treatment were doing much better. So here at the conclusion, I must say that I was surprised, because generally those kind of experiment that do not have confident such strong data. If you think we are dealing with the auditory cortex, so superior function, and with neuromodulation. So this is why all this study needs to be double-blind, placebo, randomized trial. Otherwise, data can be very, very, very complicated to analyze. We can say right now that speech discrimination in noise enhancement could be improved a lot with TMS in sensory neural hearing loss. We know that right now all cochlear implants that are compatible with 3.0 Tesla MRI are much more than safe if you want to do some TMS studies. And it seems that the effect in terms of speech discrimination in noise in patients with cochlear implant that have been treated with auditory cortex, TMS is really consistent. So these data are really promising. I think, well, we know from more studies and many others since at least 10, 15 years that in terms of electrode design or working on the cochlea, on the periphery of the auditory system, we are at a really high level. What I think we still need to understand, study, and probably could be the trigger to improve a lot the performance of these patients in regarding detecting speech noise is something that it is at a higher level, and probably the auditory cortex, since it's superficial, can be easily neuromodulated, could be an interesting target for the future. Thank you very much.
Thank you. Okay. Good afternoon. My topic is about the frequency following response to evaluate speech and noise ability for the hearing impaired students. I'm Nadia Kamal, Professor of Audio Vestibular Medicine at Ain Shams University, for whom he doesn't know me. Why we are examining the noise or speech and noise? Because it's real life communication mostly takes in noisy places. And hearing in noise is an important task for successful learning and social interaction, and especially in young children and in education. Frequency following response could be a useful tool in assessing how the auditory system process complex sound like the speech in noise environment. So we have an MD thesis that has been conducted about the effect of hearing loss on neural encoding with speech in children, and by my colleague Dr. Ghada Muharram, and supervised by Dr. Amani, Dr. Hisham, and me. And this was a big study, but I'm going only to present about the frequency following response. The hypothesis that the frequency following response, who don't know, it is a sustained component of the complex ABR that mirror the frequency, phase, and harmonics of the sound. Since frequency following response can capture pitch and timing cues that are essential for understanding speech in noisy setting, then if we can provide or measure frequency following response, it may give us insight about the speech and noise performance in young children when we don't have the ability to make it on behavioral basis, or for difficult to test children. These participants, we have two groups. First, we have normal groups, of course, so age matched to the study group to as a control to establish the norms, and the range was around 6 to 14 years old, with the average about 7.5 years old. The control group with normal hearing and normal in everything, to guarantee no other abnormality. The study group also with normal children, except they do have sensory hearing loss, mild to moderately severe, symmetrical. The classic approach that we have history taking, basic audiological evaluation, and we go for behavioral testing, speech perception measures, and open set Arabic phonetically balanced at 40 SPL. With the noise is the speech shape noise. What about the FFR? We use the equipment Biologic Navigator with the MATLAB analysis, and that measures the complex ABR, but here I'm going to focus only on the sustained response, which is the frequency following response. The stimulus was the syllabus DA, DA 40 milliseconds, and this is very important, that has been given at comfortable level, around 40 dB SPL, whether for noise or for sensorineural hearing loss. the analysis, we use the MATLAB, and then we analyze the FO and the harmonics, root mean square, fundamental frequency, and F1. Also, we go for inter-trial coherence, which quantifies consistency of the frequency following response across multiple presentations. First, stimulus to response presentation, which is called SR, and inter-response to noise, which is noise to quiet correlation, LIR. This is the complex ABR when you have the stimulus down. And this is the acoustic, and here the fistfully the electrical or the complex ABR responses, where we have the transient and sustained response. What about the results? We have for the normal children, we can look for the FFR, where we have root mean square, F naught, we call it envelope, F1, TFS and SR. We can see this inquiet and noise. We can see the bare difference between inquiet and noise. They are normal. Adding the noise had made some changes for the FFR parameters. And these changes, although it was not mild, but it's still significant. Meaning that even normal children needs to have good environment during classroom. That noise may have increased the listening effort during education. What about the sensory hearing loss? If we compare sensory hearing loss with the normal hearing for FFR measures in quiet, more or less the same. Remember that. This was a comfortable level for the sensory hearing loss, meaning that if these sensory hearing loss patients or children have good aided responses, means they in quiet, they don't have much suffering. It's more or less similar to normal hearing children. Yet, if in noise, there is a more affection and a strong affection of the F1, especially the F1, temporal fine structure, and this is very important for speech discrimination. This slide before was for the group, then again the pair difference, but we looked again to be confident. We look for each patient difference between noise and the quiet, in whether in normal or sensory hearing loss. And in the statistics emphasize again that sensory hearing loss patients has marked affection of the F1, which is temporal fine structure, and in the stimulus to response relations. This is an example, or it's two examples actually, A and B. You can see the A, it's a child, both of them is around 9 years old. And in quiet, speech discrimination was excellent. The first one is 92, while the second one is 96. However, with addition of noise, this is a behavior, of course, with addition of noise, the speech discrimination has, for the first case, decreased only within 10 points only, while the second child have decreased more than 50 points. And we will see this is a good case for good patients with noise, or noise has limited affection, while the second one, noise has marked implication in speech discrimination. And if we look for the CABR or FFR especially, you see here the stimulus where we have the good response. The stimulus and the response were very mirror image. While when you look for the second child, the stimulus and the response is widely apart, and speech ABR almost doesn't show markable waves. What about the behavioral? data, speech discrimination for normal hearing. You can see in quiet and in noise, and normal hearing had decreased mildly with the introduction of noise. However, the sensory hearing loss has decreased about more than normal hearing, which is goes with the logic, but there were heterogeneous group. When we looked for what we call noise degradation, is the difference between noise and the quiet for each patient, we see that we have good percentage of children lie within the normal curve like the normal. However, still some children, and those were about 37.5, almost more than a third of them, has unexpected or unexplained very poor speech discrimination. We looked for the why, how to predict this, whether the onset of hearing loss, cause of hearing loss, degree of hearing loss, or configuration, or the use of hearing aid. Unfortunately, all of this was statistically non-significant. So there is no way to predict from these parameters, this child, what is going to be performed with noise. Again, correlation with the word recognition to pure tone, negative correlation between pure tone and word recognition in quiet, which is, we all have this experience. When you go with the stronger or more severe hearing loss, definitely speech discrimination quiet will be more degraded. However, with the noise, there was no correlation. This doesn't mean that severe hearing loss means that they do have more aggressive effect of noise, but it was no correlated, and you can see we couldn't reach why. We couldn't even, from studying the variable which we could predict. So in conclusion, speech and noise ability cannot be predicted by traditional hearing tests, whether the pure tone or speech in quiet scores. You have to test it as a separate test. If we cannot, then we can go for objective measures. Not all children with mild to moderate severe hearing loss have poor speech in noise. Only about a third of them. And to predict or to predict in young children, we can use the FFR when you have a temper-fight structure and a stimulus response relation could highlight the impaired ability in speech and noise. Of course, early prediction of speech and noise ability can provide guide what we call personalized intervention, which is very important, whether for the hearing aid selection and hearing aid programming, cochlear implants, auditory training, and so on. Thank you.
And finally, let's conclude this roundtable by a higher level of electrophysiological testing, auditory electrophysiological testing, which is the cortical auditory evoked potential, the P1 CAPE, a golden biomarker in a cochlear implant journey. Cortical auditory evoked potentials represent the summed neural activity in the auditory cortex in response to sounds, as we all know. They reflect the neural activation of the cans in response to the spectral temporal properties of a given stimulus. And they are closely linked to the perceptual processes underlying speech perception, detection, discrimination. It's actually occur in the time window of 50 to 300 millisecond post-stimulus, P1 and 1, P2, which is the adult form, and of course we have the child form, P1 and 1. The P1 biomarker is easily measured in infants, very young children, and they does not require a behavioral response, and of course they are non-invasive, and that's why they are widely used in the cochlear implant and even in the hearing aids nowadays. Being a part of speech auditory evoked potential, the P1 can be elicited using the consonant vowel da, ba, ga, sa, whether it's synthetic or natural. giving rise to a child form or an adult form like seen here in the graph. And of course, they will provide information about the biological processes underlying speech processing. If we are using the ba, da, ga, sa in a simple way, we are eliciting the obligatory detection component of P1 CAPE. But if we are going to manipulate these sounds, we are going to get the acoustic change complex, which represents an obligatory CAPE elicited in response to change in an ongoing sound. And this change may be change in frequency, in intensity, timing, or spectral intensity changes in speech or speech-like sounds. They are, of course, have wide clinical applications, including the investigation of the neural processing of speech, assessing the central auditory function, the speech discrimination and resolution capacity or ability. This is a response of the ACC in an adult and a child. It's slightly or later in timing window to a change of vowel U. And why and how we are going to implement these two obligatory or discriminative properties of the P1 CAPE and being a golden biomarker in cochlear image journey. What's the role and when it's indicated, and it can be used once or repeated? Preoperatively, it can be used. How it can be used preoperatively, and of course postoperatively. Preoperatively, it can be used in hearing device validation. The presence of P1 at a normal latency denotes that the device, the hearing aid used, provide the sound and transmit the sound to the cortex, so there is a detection at normal timing pattern, and it provide a confirmation of how much the hearing aid setting is properly set, providing a good detection of sound at the level of the cortex. But of course, detection and not discrimination until we use the ACC, and of course it was done in our facility. On the left side, it's a typically developing P1, and on the right side, it's a delayed response. So when we see this patient, and after a proper use of hearing aid, we of course will shift the patient to a cochlear implant. Another type for validation and monitoring the P1 over time. The A curve, it's a delayed after initial fitting, while the B curve after 7 months of consistent hearing aid use. So this denotes that the child is benefiting from the device. Another aspect which is very important, the ANSD and the P1 preoperative assessment. Of course, we have a group of ANSD which are in the moderate to moderately severe vicinity of hearing loss, and you are very confused whether to implant them or to wait. So the AAA has provided us an advice to take a hearing aid trial in a certain period to be validated with the use of the cortical auditory evoke potential into speech sounds with and without the hearing aid to decide in this group of children whether to implant or no. And this is a study which was done on 2017. It's investigated the moderate to severe degree of sensory neural of ANSD using P1 with temporary modified speech syllables. And interestingly, 50% reported improvement in relation or in comparison to a sensory neural hearing loss group. On the left side, it's a normal response, the mid ANSD, and the left side, the right side is the sensory neural. If we look to the ANSD and the sensory neural, of course, there is a change and there is a response in the ANSD, although it's slightly delayed to the sensory neural. Some of the patients, when they were monitored, they get proper response like the sensory neural, and others no, and they were shifted to the cochlear implant. It provides, in addition to the preoperative indication, we have the postoperative indication for the P1 CAPE to indicate the adequacy of auditory stimulation. The first curve is activation, 3 months, 6 months. We see that after activation, continuous rehab program, proper rehabilitation program, the P1 is improving in timing and in amplitude, denoting the success of the outcome of the cochlear implant use. And this ACC, it's a good performer on the left side and a poor performer that he is detecting but not discriminating the speech sounds introduced. Also, the use of P1 not only for detecting the outcome, but interestingly for detecting the thresholds in those we cannot provide the adequate routine threshold estimation. And this study was done at Ain Shams University, master's thesis, the value of P1 speech CAPE in threshold determination. This is, we studied these stimuli, ba, ga, sa, on normal children, controlled children, and on cochlear implant children, acoustically, of course, and we have found that the sensation level used for the cochlear implant were very much related and very much compared to the behavioral thresholds. So it was concluded that the use of P1 CAPE in threshold determination, it's a very important tool guide to be used in those group of children. Sorry. هو ليه السلايد بترجع؟ And post-operatively also, as like the validation for the hearing aid, we can validate the progress through cochlear implant, as have been mentioned. And these are some of the studies that at the electrophysiological lab of audiovestibular unit at Ain Shams University about the P1 CAPE. Actually, it's examined in hearing aid users, in cochlear implant users, and even on normal hearing children, ACC and obligatory P1. Concluding highlights, P1 CAPE and ACC are good predictors and guide in cochlear implant journey. The adult morphology was observed in cochlear implant children with early implantation or with regular hearing aid use before the operation. And the P1 CAPE latency is affected by the type of stimulus used, chronological age, age of implantation, auditory training, and the regular use of hearing aid before implantation. And thank you. This was my presentation. And now we are concluding the roundtable about the electrophysiology as a good guide. I'm going to mention the home message that I think we will add, and I will hear from my speakers. And also we will open for discussion and questions. Auditory evoked potentials provide insight into the brain mechanisms underlying hearing, listening disorders, and the audiologists aim to treat. The word of auditory stimuli is far more exciting than clicks, tones. Sophisticated stimuli may evoke potentials that can evaluate the specific auditory functions. And auditory evoked potentials assess functionality and supplies information about the physiology of a certain anatomic pathway, and thus are complementary and even superior to radiological studies. And after hearing Professor Dr. Mandala, I'd like to add the role of auditory evoked potential in transmagnetic stimulation. What do you think? There is a role in such a thing? Or have you implemented in this issue?
No, I was thinking while I was hearing to the other presentation, was just thinking if we could add something and that could be measured.
To objectively assess what you are saying, which is very interesting.
That would be, that's why I was thinking of put together a collaboration with
yes, of course, it will be our pleasure. But I have a small question for you. What do you think the transmagnetic stimulation, the cochlear implant, what's the proper mechanism or the actual mechanism in this group of patients?
Well, it's not easy. I would say that since we are exciting the auditory cortex, I think we are to some extent increasing its capacity to manage a different stimulus from the natural hearing.
Yes, so I think it's not only hearing; it stimulates other areas.
It will probably. Well, it's really specific because it's neuronavigated. So close by areas shouldn't be affected. But we know that TMS can increase neural plasticity, so promote connection with other areas. So there will be for sure also this effect. Another interesting things would be to some extent to prepare the auditory cortex before receiving the cochlear implant. That is another branch of the study. So patients, probably the best way to carry on a new study would be to do TMS before cochlear implant. So in order, it is in a way to prepare the auditory cortex to receive the cochlear implant.
Okay,
but it's really an open field. So that's the first demonstration in humans. So it's
but it's interesting, really interesting. Professor Dr. Nadia, do you want to add any comment?
Thank you, Dalia. I'm at the end, so you are very bright and doing a very good job. Thank you very much.
Thank you. Okay, thank you, Chairperson. Thank you, everybody. Okay. Yes, of course.
It's for you, actually, the question about the TMS and how durable is this effect of improving the speech?
That's a really good question. We're still waiting the answer because the study didn't start from a long time, but it seems to be at least from 3 to 6 months. Then we have to follow up the patients. In patients with a hearing aid, it was pretty reliable over time. It may be that this patient may need another trial, but I really don't know when and if they will need it. I would say probably yes.